It's a standard afternoon in your clinic. You glance at the chart for your next patient and the chief complaint simply says, pigeon-toed. You walk into the room and find anxious parents armed with internet research watching their perfectly happy toddler occasionally stumble around the exam room. We've all been there. Intoeing is one of the most common concerns we see in pediatric outpatient practice. And in these visits, our job is really twofold. First, to quickly distinguish normal developmental variation from true pathology, and second, to reassure worried parents with confidence. The good news is that the vast majority of cases are completely benign. Most fall into what we can think of as the benign rotational triad, where the cause depends largely on the child's age. The rotational issue may arise from the foot, the tibia, or the femur. So let's walk through this triad by age group, focusing on the classic presentation, the key physical exam findings, and the practical management points you can confidently discuss with families. Starting with infants under 1 year of age, the most common cause of intoeing is Metatarsus adductus. This is usually due to intrauterine molding. Essentially, the forefoot becomes curved inward because of positioning in the uterus. Clinically, the classic finding is a C-shaped or kidney bean appearance of the foot. The lateral border looks convex, while the medial border appears concave. One important differentiator is that unlike clubfoot, the heel and ankle remain neutral and flexible with normal range of motion. Management is usually very simple. Reassurance. About 90% of flexible cases resolve spontaneously by 1 to 2 years of age. For semi-flexible feet, parents can perform gentle outward stretching during diaper changes. Only rigid deformities that cannot be brought to neutral by around 6 to 9 months require orthopedic referral for serial casting. Surgery is extremely rare. As children enter the toddler years and begin walking independently, the source of intoeing usually moves higher up the leg. Between 1 and 3 years of age, the most common cause becomes internal tibial torsion. Again, this is largely a residual effect of intrauterine positioning. The classic appearance is straightforward. The kneecaps point forward, but the feet point inward. These children may also have physiologic bowlegs, which makes the intoeing appear even more pronounced and explains why parents often report frequent tripping. The key exam maneuver is the thigh-foot angle. With the child prone and the knees flexed to 90 degrees, you'll see the foot angled inward relative to the thigh. Management here is entirely observational. As the child grows and walks more, the tibia naturally derotates. Most cases resolve by 4 to 5 years of age. And this is an important counseling moment. Special shoes, wedges, and braces do not work. Evidence consistently shows they provide no benefit and only create unnecessary cost and frustration for families. Now, in children between 3 and 10 years old, the most common cause of intoeing is increased femoral anteversion. This refers to an excessive inward twist of the femur. On examination, the hallmark finding is kissing patellae, where the knees point toward each other when the feet are aligned forward. Parents may also describe an egg beater running style. On hip range of motion testing, these children show markedly increased internal rotation and limited external rotation. These biomechanics also explain why many of them prefer W-sitting. And this is another great opportunity for reassurance. W-sitting does not cause femoral anteversion. It's simply the child's most comfortable sitting position because of their anatomy. Management remains conservative. Most cases gradually improve on their own by 8 to 10 years of age. Surgery is reserved only for severe, functionally limiting deformities later in childhood. Of course, while the benign rotational triad accounts for most cases, we always need to stay alert for red flags. Rigid multiplanar deformities may indicate clubfoot and require early orthopedic referral. Intoeing associated with spasticity, hyperreflexia, or delayed milestones should raise concern for cerebral palsy. And asymmetric thigh folds, leg length discrepancy, or limited hip abduction should prompt evaluation for developmental dysplasia of the hip. So the key takeaway in clinical practice is this. If the intoeing is unilateral, painful, rigid, progressively worsening, or associated with developmental delay, think beyond normal variation and investigate further. But for the vast majority of our clumsy W-sitting children, the best treatment we can offer is confident reassurance. Educate the parents, avoid unnecessary braces and corrective devices, and allow normal growth and development to do the rest.